Good evening, friends. Today I am going to discuss a very important topic for the ICU critical care management, that is acute respiratory distress syndrome. And in final year anesthesia examination, it is also an important question. And in practicals also, a lot of questions are asked. And concept building of ARDS is very important because it gives us insight into hypoxemic respiratory failure and PaO2 and SpO2 and how to manage the ARDS. It gives us a deeper idea about ICU management of such cases. So what is ARDS? It's acute respiratory distress syndrome. Acute respiratory distress syndrome, according to the Berlin definition, it's a conference that has been convened to define the ARDS definition. Earlier, there was a conference between the American and European specialists regarding the acute respiratory distress syndrome definition and its identification. So there were a lot of confusion about acute lung injury and respiratory distress, and so the Berlin definition has more or less largely clarified what is acute respiratory distress syndrome. So there are certain criteria. Not going into detail into historical perspective, we are directly going into the acute respiratory distress criteria according to the Berlin conference. First and foremost is the timing. So any insult or any predisposing factor that leads to onset of the problem or onset of the infection, so it has to be within 1 week from the detection to the occurrence. So it has to be within 1 week. So acute onset, and it has to be within 7 days of insult. It may be infectious, it may be inhalational injury, it may be traumatic. There are a lot of causes and lot of risk factors that we will discuss later on. But whatever the inciting factor, this has to be within 7 days of the onset of sign and symptoms. So it has to be acute. Acute presentation is first criteria. Second one is it has to be X-ray bilateral homogeneous opacities, ground glass appearance. In X-ray, there has to be ground glass appearance and homogeneous opacities. There should not be evidence of pleural effusion or empyema or a nodule. Third is there should not be any heart failure features. So it should not be cardiogenic pulmonary edema. So the cause of edema has to be respiratory. So edema has to be non-cardiogenic edema, non-cardiogenic pulmonary edema, and originated due to the hydrostatic pressure or due to the infectious pathology. It's not because of heart failure. So one is timing, had to be acute. X-ray should show bilateral homogeneous opacities, ground glass, and there should not be evidence of pleural effusion or empyema. And third one is the non-cardiogenic pulmonary edema. There should not be any heart failure involvement, which will be detected by various criteria. So that's why they have earlier in the earlier definitions of ARDS, they have included PCWP, pulmonary capillary wedge pressure, has to be below 18 mmHg, and above 18 mmHg it goes into the it goes into the universe of heart failure. So congestive cardiac failure has to be ruled out. Fourth is predisposing factor. Predisposing factor there should be some causative agent, or there should be some risk factor. So predisposing factor should be present, like pneumonia, inhalational injury, drug overdose, trolley aspiration. So these are the predisposing factors. And most important criteria is based on PaO2 and FiO2 ratio. PaO2 and FiO2 ratio, PF ratio. PaO2 by FiO2 ratio. According to that, normally the PaO2 FiO2 ratio is more than 400. And in this case, if it is 200 to 300, it is mild ARDS, and 100 to 200 moderate ARDS, and less than 100 is severe ARDS. So PaO2 by FiO2 has to be within less than 300 centimeter of water. Less than because it's a ratio, so it has to be less than 100. And it is taken into mmHg, not with the centimeter of water. But there is a catch. If the patient is on ventilator, the PEEP has to be above 5 centimeter of water. So PEEP is required to calculate this PaO2 FiO2 ratio. So it is very important to learn the criteria to decide ARDS. So let's repeat. First is timing, acute, within 1 week of insult. Second is the origin of the edema. Origin of edema should be respiratory. There should not be any evidence of heart failure. X-ray, bilateral homogeneous opacities, and PaO2 FiO2 ratio less than 300 mmHg, and fifth one is predisposing factor. So these are the 5 criteria to define acute respiratory distress syndrome. When we are learning about ARDS, very often we have to compare the PaO2 and SpO2. So there is a simple formula to remember about the PaO2 and SpO2. One thing that we all know is that if PaO2 is 27 mmHg, then SpO2 is 50%. So this is a basic formula that has to be remembered. It's around 25 and 50. But later on, we have to remember a formula 4, 5, 6, 7, 8, 9. So if PaO2 is 40%, 40 mmHg, then SpO2 will be 70%. If the PaO2 is 50, the SpO2 will be 80%. If the PaO2 is 60, SpO2 will be 90%. So accordingly, we can calculate the SpO2 and PaO2, and we can conceptualize the level of distress of the patient. So what are the causes of ARDS? One is infectious, one group is infectious causes and another one is non-infectious causes. Infectious causes include pneumonia, bacterial, viral or fungal, and next one is sepsis, shock, severe sepsis. And in non-infectious causes, most important one is aspiration pneumonitis. Second is because of blood transfusion related lung injury. Third is inhalational lung injury, like during the burning the carbon monoxide soot inhalation or various poisonous gas inhalation. Polytrauma, fat embolism. There are various other causes also, like near drowning, drug overdose. So these are various causes of ARDS. Pathological phases of ARDS can be divided into three phases: exudative, proliferative, and fibrotic phase. EPF: exudative, proliferative, and fibrotic. Initially up to 7 days from the insult to the this phase is around 7 days, and this is 7 to 14 days, and this is 14 to 28 days. This is a rough idea. This is the disease progression. If the intervention has not been done, the disease will progress like this. What is exudative phase? Exudative phase mainly involves neutrophils. Neutrophils is the primarily type 1 respiratory failure. The fibrotic phase is a type 2 respiratory failure. Two important cells that has to remember during the pathology of exudative is the neutrophil infiltration, and second one is the cytokine storm, you can say, or degranulation of the neutrophils will release proteolytic enzymes, which will lead to hyaline membrane formation. These are the pathological points, they in nutshell only. You can elaborate it, I will explain it later on. Hyaline membrane formation, cytokine storm, and proteolytic enzyme secretion because of neutrophil, and type 1 respiratory failure is there. And important point is type 1 pneumocytes are involved here, and in fibrotic type 2 pneumocytes are involved. In type 2 and here also type 2 pneumocytes are involved. What happens in the exudative phase? Because of insult, septicemia, bacterial, viral, toxemia, endothelial injury, and leaking get started, and alveoli, this is alveoli, and this is capillary. So the leaking start to happen, and by this way the neutrophils comes into alveoli. So in alveoli the neutrophils cross from the capillaries, and in the and then neutrophils gets they release their granules. Neutrophil granules are released. They contain granules. They contain various proteolytic enzymes. So these neutrophils contain various neutrophil granules contain various proteolytic enzymes and histamine, serotonin, and various cytokines. So, and also the RBCs cross here, and some hydrostat, because of hydrostatic pressure the fluid gets accumulated here. So there is hyaline membrane formation. So this is primarily basically the exudative phase pathology, and this will later on go into the proliferative phase. Where there is type 2 cells, their proliferation occurs, and lymphatic drainage gets started resolving. So whole pathology is going towards the resolution, and the alveolar capillary membrane is getting repaired. Finally, the fibroblast, in the fibrotic phase, fibroblast will increase, and there, because of them, the fibrosis is going to happen in future. So fibroblast proliferation will lead to increased fibrosis. So these are the basic idea about pathophysiology. Exudative phase will lead to endothelial damage, leaking of RBCs, neutrophils into the alveoli, and formation of hyaline membrane. Type 1 pneumocystis are involved. In proliferative phase, type 2 pneumocystis are involved, lymphatic drainage and repair. In fibrotic phase, fibroblasts were recruited, and fibrosis will occur. Later on, if the intervention is not properly done, patient can develop the fibrotic lung disease or interstitial lung disease. So this is basic pathology. Before proceeding further, there are some concepts that are required to be understood to proceed further. The concepts are biotrauma, atelectotrauma, barotrauma, and volutrauma. What are these things? The biotrauma is when patient is on ventilator, the pressure generated through the ventilator for the continuous inspiration and provide full control of the ventilation of the patient, there is continuous stretch and stress over the stretch and stress on the alveoli, on the parenchyma of the lung, and this will lead to, though there is no structural damage in biotrauma, there is no structural damage, but because of stress and strain, there is release of cytokines, neutrophil activation, and this will take the similar course of action like ARDS, and sometimes only the ventilator is the cause of multi-organ failure because of this pathway. Electrotrauma, ventilator will lead to cyclic opening and closing, cyclic opening and closing of the airway. This cyclic opening and closing of the airway result in high velocity shear forces created by opening of the collapsed airway, which can damage the airway epithelium. This will be a source of lung injury and release of inflammatory mediators and cytokines and further deterioration of the condition. Barotrauma is because of high pressure, the high airway pressure. There is a damage to the parenchyma and similar further course of action. And in volume trauma, the stress and strain because of high volume. Now, what is lung protective ventilation? In ARDS, we usually go ahead with the lung protective ventilation. Lung protective ventilation. What is lung protective ventilation? As I have mentioned, all those biotrauma, value trauma, so to safeguard the lungs from those injuries, because we don't want the ventilator to be one of the cause of the progression of acute respiratory distress syndrome. So lung protective ventilation is very important. How to proceed with lung protective ventilation? The target of the lung protective ventilation is low tidal volume, 4 to 6 ml per kg body weight, and plateau pressure has to be below 30 mmHg, and respiratory rate should be below 20 per minute, and PaO2 should be above 60. On FiO2 less than 40. So these are the targets. But to achieve these targets in ARDS, it is quite challenging. So we start with when the patient is on ventilator, ARDS patient who is hypoxemic, and it is going to be difficult to maintain his PaO2. In that case, we have to go for the lung protective ventilation, and in that case, we'll start with the high tidal volume. It's 8 ml per kg. It's not very high, but a slightly higher side, 8 ml per kg. And you will keep the P5 8 ml per kg tidal volume and P5, and lowest FiO2, on which lowest FiO2 will start with 100%, but will gradually decrease 85%, 60%, 65%, where it can be satisfactorily maintain the SpO2 of 88 to 95%. SpO2 88 to 95%. So minimum FiO2 has to be kept, and it has to be 85 to 90%. And then every 1 hour, every 2 hours, we have to reduce the tidal volume at 1 ml per kg body weight hourly. But we have to maintain this SpO2, and if SpO2 is getting maintained, then we can decrease tidal volume, and target is up to 6 ml per kg body weight. The calculation of tidal volume, the body weight has to be predicted or ideal body weight. Predicted or ideal body weight. So what is ideal body weight? Ideal body weight is 50 plus 2.3 into height in inches minus 60. In female, 45.5 plus 2.3 height in inches minus 60. So this is ideal body weight. So according to that, we have to calculate. So first step is setting up the tidal volume and maintain and decreasing the FiO2 up to a satisfactory SpO2 level, and then we have to decrease the tidal volume to 6 ml per kg. But then second step is we have to see plateau pressure. If it is more than 30 mmHg, 30 centimeter of water, then we have to decrease the tidal volume at 1 ml per kg until the plateau pressure comes to less than 30. So tidal volume is further reduced to up to 4 ml per kg body weight. From 6 ml per kg body weight, it has reduced to 4 ml per kg body weight to maintain the plateau pressure below 30 centimeter of water. This is second step. So tidal volume is further reduced. Now we have to see in the third step, we have to monitor the ABG. ABG, respiratory acidosis. pH. If pH is between 7.15 to 7.30, then we have to do something to decrease this respiratory acidosis. So respiratory rate is increased up to 35 per minute, and we have to see whether this pH is getting better or not. If pH is not getting better, then tidal volume is increased at 1 ml per kg body weight up to 6 ml per kg tidal volume. So optimal goal, as I earlier mentioned, tidal volume 6 ml per kg, plateau pressure less than 30 mmHg, SpO2 88 to 95%, pH 7.35 to 45, and PaO2 above 60. This is a lung protective ventilation setting. What is permissive hypercapnia? Permissive hypercapnia. Permissive hypercapnia. It's a increase in PaCO2 because of this protective lung ventilation. Protective lung ventilation. Low tidal volume will lead to less clearance of CO2 from the alveoli, which will lead to accumulation of CO2 into blood, and this will lead to rise in PaCO2. We will allow this rise in PaCO2 up to a certain extent where there is no harm. So up to 65 to 70 mmHg PaCO2 is allowed to rise. Although there are lot of side effects of this, but they are not as much harmful as the hypoxemia in that situation. In severe ARDS on mechanical ventilation, we have to allow permissive hypercapnia because patient is not maintaining any adequate PaO2 or adequate SpO2. So limit of tolerance has to be taken care of. So prone ventilation. All important topics I will discuss so that we can write about those things. We can know something about all those points. Prone ventilation. Prone ventilation. So proning. How the proning gives benefit? What happens in supine position? The mediastinum and heart has a compressive pressure over the dorsal aspect of the lung, dorsal lung areas. So it is a kind of weight, and there is collapse of alveoli because of mediastinum, the heart in supine position, as well as the hyaline membrane formation and non-cardiogenic pulmonary edema. So there are fluid accumulation in the alveoli in the dependent areas. This is also a wet lung type of situation, which is also a weight and collapse and consolidation of the dorsal area. So overall, the area level for the area level for the respiration or for the proper alveoli to breathe is lesser. This is CT scan cross section, and this is mediastinum, heart and mediastinum, and this is the edema fluid accumulated bilaterally. So as we can see, the areas level are like slightly like this, but when the proning happens, what happens is in the prone position, this mediastinum is here, and the edema fluid accumulated, and overall the area for the better alveoli, area level for the better alveoli for ventilation is increased in the dorsal, in the prone position. And why the area is more level is because of the reason that I have explained already. In supine position, mediastinum and heart, the weight of mediastinum and heart leads to a compressive effect over the various alveoli which are situated dorsally, and as well as the fluid accumulation in the dependent areas because of non-cardiogenic pulmonary edema and wet lung. So it also acts as a weight which compresses the alveoli. So because of these two reasons, the area is very less level for the lungs to breathe, and in the dorsal position, in the prone position, the more alveoli are recruited. That's why it is called as baby lung. In ARDS, the number of alveoli or level for ventilation is very less because of de-recruitment, because of collapse, consolidation, fluid accumulation. So the number of alveoli is reduced. So since the number of alveoli is reduced, so it becomes the lungs become like baby lung type of situation, where the proper adult lungs are not functioning. It functions equivalent to the babies. The area is so reduced. So in proning, what are the things that are important to take care? 5 persons are required to change the position. 5 persons are required to change the position, and consent is important for the family. We have to explain about all the side effects of the proning and positive effects of the proning. The side effects are pressure sores, edema, swelling of the face and eyes, trauma of the eye, or trauma due to positioning, and sometimes the disconnection of the trachea, disconnection of the endotracheal tube from the ventilation. So apnea is the risk. Sometimes the lines are out because of positioning. All these risks has to be explained to the family. The team briefing is important. The team that is going to participate, and the team has to know the roles. Team member has to know their roles, what they are going to do. Each person has to know their own work, and proper sedation or muscle relaxation is important, because positioning is painful, very painful for the patient. So it is very important for the proper sedation and muscle relaxation. Eyes has to be protected at all cost, and the head has to be rotated side by side every 2 hourly, and head has to be rotated every 2 hourly. Position has to change. Air mattress, and before proceeding for the prone position, all the lines has to be secured, and endotracheal tube has to be secured, properly ventilated, ventilation has to be checked, and there are a lot of problems that are going to happen because of prone position, like we are not able to do proper suctioning and feeding, and other things like physiotherapy, and there are a lot of discomforts, a lot of cumbersome things that happen due to prone position. We cannot do CPR if required. There are other important things, 2 hourly head position change, and hand change, and swimmer's position, right and left, has to be changed every 2 hourly or 3 hourly, and now what are the scales that gives us idea about sedation and agitation of the patient? So that is Richmond agitation sedation scale, RASS, Richmond agitation sedation scale. It has following grades. At the zero score, the patient is calm and alert. At -1, it is restless. -2, agitated. -3, very agitated. And -4 is combative. And +1 is drowsy. +2 is sleepy. +3 is very sleepy. +4 we can say sleepy. In place of sleepy, we can say sedated. So mildly sedated, moderately sedated, and severely sedated. At +5, patient is in coma. So this is the Richmond agitation sedation scale. And for pain, we have to follow the behavioral pain score, BPS, behavioral pain score, where face action and upper limb action and tolerance to ventilator has to be checked. Face, if the face looks calm, normal, then it's normal, and then face is rigid or tight, so very tight or mildly tight, and patient is grimacing. So normal, tight, and grimacing. Similarly, upper limb movement, flexion, totally retracted, flexion or totally retracted, localizing. Similarly, these are the various criteria. We can go ahead with the proper details through the Google. And tolerance to ventilator, patient is getting fatigued or fighting, tolerating. So there are various grading. So behavioral pain scale has to be utilized. On the behavioral pain scale, if less than 1 is no pain, 1 to 5 is acceptable pain, and more than 5 patient is in pain, and we have to give some medications. What are the medications that are given for the sedation purpose, pain and sedation? Fentanyl, bolus and infusion, propofol, bolus and infusion, remifentanil, ketamine, and dexmedetomidine. I'm not going to detail with the doses and all other their side effects, but in ICUs there is a uh, there is a guideline from the Critical Care Society. There is liberation from the ICU, liberation from the ICU. It has A to E points, A, B, C, D, E, and I'm not going to detail of that, but the gist of that is that it is important to mobilize the patient as soon as possible. A patient on ventilator, it is important to extubate as soon as possible. It is important to give a holiday period or give a rest period from we have to stop muscle relaxant in between. We have to stop the sedation. We have to awake the patient. We have to give the spontaneous breathing trial or awake breathing trial. So, and awakening, mobilization, patients as soon as possible, extubation, mobilization, awakening, sedation free intervals, and muscle relaxant free intervals. These are the basic important things has to be done in ICU patients so that the recovery will be faster. Nutrition is very important. It has to be started within 48 hours of the admission, and bowel sounds absent is not a criteria to stop the enteral feed. We often hear that bowel sounds are not coming, but we have to start the enteral feed. Enteral feeding. How the calorie is calculated? Body weight into 25. This will give an idea about kilocalorie. How much kilocalorie is required per day? Ideal body weight, predicted body weight into 25 kilocalorie per day. How much protein is required? Protein 1.2 to 1.6 gram per kg body weight, and similarly fat is around 1 gram per kg body weight. So accordingly we can use the formula to calculate how much enteral feed we are going to give. The name of some enteral feeds are osmolite, isonom, and the osmolality is around 300 milliosmoles. There are various other names also. Enteral feed, the primarily 70 to 80% energy is coming from the carbohydrates. Then we have to supplement the fat content and protein also, and then multivitamin and minerals. Fluid is also very important topic in ARDS. In case of severe sepsis, patient is not able to maintain the PaO2. In that condition, since it is a non-cardiogenic pulmonary edema, we have to give a restricted fluid strategy. We have to follow restricted fluid, because patient is already having pulmonary edema, we cannot give the fluid and increase the hydrostatic pressure and increase more edema fluid. This will worsen his situation. So we usually start diuretic, in that case furosemide 10 mg twice BD or 20 mg BD, and usually the maintenance fluid is continued. Maintenance fluid is around very less, it is 20 ml per kg body weight, but we have to evaluate continuously. Evaluate the CVP, we have to keep the CVP below 4 or 6, maintain the MAP more than 70 mmHg, and if PCWP can be seen, it has to be below 18, and pulse pressure variation and stroke volume variation, if it is there, then it has to be kept below 10. We can do 2D echo to see the RV filling and IVC size, and auscultation if the creps are increasing and tachycardia is happening, BP is falling down, then we can reduce it further to 15 ml per kg or stop, and we continue the 200 ml intermittent boluses with cautious approach. So fluid has to be restricted and kept on negative fluid balance. If the patient is already having a frank pulmonary edema, then we cannot start the fluid in this case. Corticosteroids, though doubtful recommendation, but methylprednisolone 1 milligram per kg is recommended, and we can gradually increase up to 2 milligram per kg up to 21 days. It's OD or BD, and the positive effects of methylprednisolone is decreasing the inflammatory condition and decreasing the cytokine, so it will help in healing. It has to be started early, within 7-10 days. What to do when there is refractory hypoxemia? Before proceeding further, we should learn a general idea. If a ARDS case comes into the emergency, we will start with the high flow. Now, we will start with the reservoir mask. The reservoir mask with 100% oxygen. If it is not able to maintain PO2 above 60, then we go with HFNC, high flow nasal cannula. High flow nasal cannula has a flow rate of 40 to 60 ml per minute oxygen, ml per kg, 40 to 60 ml per kg, and FiO2 is kept generally 90 to 100%, and temperature is around 37 degrees. So HFNC is used. It provides a mild PEEP and continuous flow. It has a humidified and temperature maintained air, so it is also comfortable for the patient. Then if it is not able to maintain, then NIV CPAP is given, and after CPAP we have to go towards the ventilator. On ventilator, low tidal volume, lung protective strategy, and if it is not able to maintain, then we have to do for prone positioning and recruitment maneuvers in case of a refractory hypoxemia, despite of doing optimizing the treatment and prone positioning. So how we are going for the recruitment maneuver? Recruitment maneuver is done utilizing the CPAP mode for the 40 seconds, 40 centimeter of water, pressure of say 40 centimeter water for 40 seconds, CPAP. We can use sigh maneuver on the ventilator, sigh maneuver, or pressure support mode. Pressure support mode, pressure up to 50 mmHg and PEEP up to 25 mm 25 mmHg. So pressure support mode, CPAP. So these are the things for the recruitment. Or we can use high tidal volume intermittently, 10 to 12 ml per kg body weight, high tidal volume. This will also provide lung recruitment. There are few things like high flow nasal oxygenation, high flow oscillatory ventilation, high flow oscillatory ventilation, where low tidal volume, 1 to 2 ml per kg tidal volume, very low tidal volume is given with very rapid pace. The cycle is 300 cycles per minute, but it has not given any benefit to the patient, so this is not used much. High flow oxygen, and then nitric oxide inhalation. It lead to pulmonary vasodilation, and it will decrease dead space. So for initial 2-3 days it gives benefit, but later on there is no prolonged benefit. There it has a side effects also. Okay friends, so more or less important points are covered, and we'll discuss the remaining parts in later on. Thank you.